Hi, everyone. Thanks for joining the Health First podcast. We're so excited to bring Dr. Scott Cohen and Dr. Fiona Collins with us today, talking about safeguarding the air we breathe, part one. In this podcast, we'll be talking about SARS-CoV-2 is airborne and some recent findings that we're all learning and uncovering. We'll also be talking about dose-related exposure, what's happening in schools today, and we'll also be looking at monitoring and ventilation. So without further ado, I'd like to introduce you to Dr. Scott Cohen. He is a practicing physician at Bassett Healthcare Network, and Dr. Fiona Collins, who is an infection prevention expert. Fiona, hand it off to you.
Thank you, Grace. Well, as we all know at this point, after a very long year, SARS-CoV-2 is airborne. It's unequivocal. We also know that there are extremely small particles, less than 5 microns, that are very easily inhaled into the depths of the lungs. We still don't exactly know the infectious dose, but we do know it's highly infective. And we've also learned more about that with recent findings. Scott, I know you read something recently about air quality. There were some findings by an engineer.
Yeah, thanks, Fiona. It's very interesting. I think there's kind of a general thought out there that, you inhale one viral particle and you get infected. And that's not true with SARS-CoV-2, nor is it true with the flu or any other virus for that matter. There's a dose-related exposure that needs to happen in order to, get infected. And that's why we say wear masks. Masks don't eliminate the virus, but they reduce your dose and thus decrease the risk of getting infection. Some researchers have estimated that it takes about 300 particles to become infected. Typically, it's about 2,000 to 3,000 for other viruses. So if you think about it, it's really a highly infectious disease. It's basically 10 times more infectious than some other diseases. And I think, honestly, when we think about this, it really just helps us figure out what do we need to do to decrease the risk of getting exposed. So I'll turn it over to you, Fiona. What are we doing, in schools right now, kind of to decrease exposure, and how are things changing?
The schools have learned a lot in the last few months. They've found masks to be effective, which is not surprising. Social distancing, so they've been keeping the students apart. They've done some hybrid learning, as a lot of online learning, but really the mask and the distancing have been found to be very effective. The daily temperature checks and the disinfection, deep cleaning of surfaces, as they would refer to it as, has been not found to be as effective as the masking and the distancing. Still plays a role, but not quite as important. But as we know, the CDC guidelines were just updated last week. And they've reduced from 6 feet to 3 feet the distancing for K-12 students. And that's based on the latest scientific findings. As we know, Scott, for the other students, the younger students below K-12, they're still recommending 6 feet distancing unless they can really split them out into cohorts. Mm-hmm. But I think some of the other information that we found on the super spreading and super spreading events is actually also very interesting.
Absolutely. And it's really interesting too, because, Fiona, you already said it's pretty obvious now, and increasing bodies of evidence keep showing that coronavirus is airborne. At first, we thought it was large droplets and 6 feet were adequate. Now I think we know that, SARS-CoV-2, can travel well beyond 6 feet in aerosols. It can be from people talking, shouting, singing, just breathing. You talked about these super spreader events, and some of the super spreader events have been, like church services, people are singing. It's really, it's interesting. We wouldn't have thought this, 2 or 3 years ago. And one of the things we think about for indoor air spaces is, how do we monitor these things? How do we, you can't look around. Okay, you can see dust in the air when sun shines through a window, things like that. But how do you monitor if there are infectious aerosols in the air? And honestly, you can't. There are some devices out that you can, test airborne particles, but, they're not practical. They take a fair amount of resources to use. and they just are not practical for everyday use. They may be practical for a large organization, to test once or twice. But there are some things that I think we're starting to think about as proxies, and they seem to bear out, doing some research with environmental engineers at the Focus. And one of them is, outdoor CO2 levels are about, 415 parts per million. And that's mainly due to fossil fuels where they've gone up over a few years. But interesting, we know that indoor carbon dioxide can be 800, 1,000, 1,200 parts per million because we exhale carbon dioxide. So think about it. If you have really good ventilation, by that I mean air exchange with outside air, you'll see that CO2 levels are low. And I will admit, we don't know what the optimal indoor CO2 level is, unfortunately, but I'm sure we can surmise that as low as possible, close to outdoor air would be best. Is that 800, 900, 500? We just don't know. But what we do know is if you monitor those CO2 levels and increase ventilation in those areas where it's of highest amounts, that it does decrease, or at least we believe it decreases the risk of transmission. And there are other findings with, what happens in the wintertime. Do particles change because of humidity? There are other things that may happen during the winter, and when humidity drops and the temperature drops, it may be a bit more difficult to ventilate spaces. But we do know that it probably does have some effect to improve that. So Fiona, I don't know your thoughts on that, or is there anything else we can do potentially to?
It's really logical when we think about it. If you have air exchanges, then you're also exchanging the air that's already in the room that people have been breathing out. They've been talking, they've been speaking, they've been maybe laughing and sneezing. So if you're changing the air out more often, you've got better ventilation. You're obviously taking some of the virus and other particles with the air as it's changed out. So from that perspective, it's logical. So certainly we need good ventilation. And that was one of the other things they found with the schools, is that using portable air cleaners, monitoring, and good ventilation would help. So there is a general recommendation to have good ventilation. If we think about some of the indoor events and the super spreaders that you were talking about, Scott, there's also a gradation on, well, which people are in the room.
Mm-hmm.
If you've got groups that are, obviously if they're uninfected or largely uninfected or a very low viral dose, that's quite different to a larger group of infected people proportional to the whole group, and depending on the viral load. And at the extreme end, that would be the most severe situation, you've got elderly people with a high viral load. So there really are gradations, but it's become clear that good ventilation is definitely one of the key strategies going forward in trying to control the air and, in fact, cleaning the air as well.
Yeah, and I think, we're going to, I think, speak in our next podcast about, how we're going to, or what we can do potentially with indoor air quality, in addition to, increasing air exchange with outside air, i.e. reducing CO2 levels as a proxy for better air exchange. But I think we're also going to really get into how, some of the theories about, doses. So why do some people get really severe COVID disease and some people don't? Why do, and there's a lot of theories behind that, but there are some theories out there related to the dose of exposure, and how clusters are affected by that, and how some clusters can have more severe disease within a cluster. And it's really interesting. I can't wait to talk about that next time. And then also, I think Fiona, you said we were going to talk about air purification as well. Is that correct?
Yes, and I'll touch on that at the end again, just very briefly. I think the other interesting thing is the study that we were discussing earlier, where they found that really the initial viral load that the person acquired from the source was suggested to be predictive of the likelihood of disease and how severe it would be. So I think that again ties into not only ventilation, but also in other ways ensuring good air quality. So I know we were going to discuss monitoring ventilation, and we were talking about monitors earlier, Scott.
Yeah, absolutely. I think there's a couple different, the big monitors that I'm interested in are, CO2 level monitors. And there are some out there, they're fairly inexpensive. Those have been out for years because they're used in a lot of different areas. But I think they're things that you can use on a regular basis. I don't want to say every day. Who's going to go around, measuring CO2 in areas. But if you can get, like, say, your normal number of people in a room and a normal temperature day with your typical amount of ventilation, meaning the typical number of windows open, the heat set at a certain amount, the airflow going with circulators at what is normal, and you measure it and you say, wow, it's much higher than all the other rooms in the building. Well, you could say, all right, well, this room needs some remediation. And again, I really can't say that this number of CO2 is better than that number, but we can say that lower is better and higher is worse. So we can say that, if you have any outlier rooms, those are the rooms I would focus on, because, if some of your rooms are 6, 7, 800 parts per million and one of them is 1500, you work on the 1500 room and just get everybody more towards the mean. I wish we could say, yeah, shoot for 800 or shoot for 900 or whatever it is, but we really can't say that. But I can say gyms, restaurants, bars, schools, other things that are, trying to stay open or safeguard our public and kids are really trying to, move forward with these sort of technologies in order to help.
Right, and the carbon dioxide monitors that have been developed, they're pretty easy. They're straightforward to use. It's not a complicated test. There isn't a delay in timing. If you look at some other tests that are being performed, it's a 2-3 day delay. You don't really want a 2-3 delay with ventilation, but when you get fairly immediate results and adjust your ventilation, it's a great move. It's proactive, and it really does indicate when you need to improve ventilation.
Absolutely. So I guess, as we wrap it up here, with this podcast, we really look forward to talking about some of the further technologies. These are coming out. These are out right now, the CO2 technologies. I think when we start to record some of the podcasts in the next few days, there'll be other technologies that are coming out quickly, because it just seems it's something every day, and we explore things, and we'll try to help out the audience by, pre-exploring these things. We're not selling here. We're really trying to, explore technologies that can help people open their schools, open their restaurants, and their offices and things like that. But we'll try to, find what technologies are out there to help, and, try to vet at least, not necessarily the individual ones, but what exists out there, how they work, and do they have some evidence to help. Some may not have evidence, but still may be helpful. We're in that kind of mode right now where things are changing so quickly. It's going to be difficult to know everything about everything in this space, right?
And it's actually a really positive thing, because it means we're learning more, we're finding out more, we're learning more how to combat it, in addition to vaccination and other methods that have already been used. Yep. And with that, in part 2, we're going to discuss air purifiers as well as air disinfection techniques. We'll look forward to seeing you again in our next podcast. Thank you.